Myself Namira and I will be teaching clinical pharmacy. Syllabus clinical pharmacy for D.Pharm. First topic is clinical pharmacy, its definition, its scope and development in India and other countries. Second, technical definition, common terminologies used in clinical setting and their significance such as pediatric. Pediatric is children's. Geriatric is elderly patient. Antenatal care is the care during the pregnancy, and postnatal care is after the baby is born, the care of the baby and the mother. Third is daily activities of clinical pharmacist, definition, role and procedure. Ward round participation, how ward round is carried out. Treatment chart review, how patient treatment chart is reviewed by the clinical pharmacist on the daily basis. ADR monitoring, that is adverse drug reaction monitoring. If the patient is having any ADR, that is to be monitored on the daily basis. Drug information and poison information. If any new drugs comes, the information about that. If any poison antidote newly comes, its uses. Medication history, how to collect the medication history of the patient. Patient counseling, how to counsel the patient for the disease, how the disease is spreaded, its causes, its etiology, its signs, symptoms. Interprofessional collaborations. Fourth is pharmaceutical care, its definition, classification of drug related problems, principle to provide pharmaceutical care to the patient. Fifth is medication therapy management, how to manage the medication therapy according to the multiple disease condition of the patient. Home medication review, asking the patient about how the medication he is taking. It is known as the medication home review. Sixth, clinical laboratory test used in evaluation of disease state, significance and interpretation of the test result. Hematological test, test related to blood disorders and blood cells. Liver function, how our liver is functioning. Renal function, how our kidneys working. Thyroid test, hormonal test, the functioning of thyroid and antibodies. Test associated with cardiac disease, how our heart is working. Fluid and electrolyte balance, how electrolytes and fluids are working. Potassium, calcium, magnesium in our body. Pulmonary function test, test related to our lungs, how our lungs are working. Seventh, poisoning. What is poison? Types of poison. Clinical manifestation, that is the etiology, sign and symptoms of the test, and antidotes used to cure the poison. Eighth, drug and poison information center and service, its definition, requirement, information, resources with example, and its advantage and disadvantage. Number 9th is pharmacovigilance. What is pharmacovigilance? Its definition. Pharmacovigilance is assessment, detection, management and prevention. It is to keep a check on the drug after when it comes in the market. It's a drug safety. Its aim and scope, overview of pharmacovigilance. Number 10th, medication errors. Definition, types of medication error, consequences and strategies to minimize medication error. How to minimize the medication errors. LASA drugs. LASA drugs is look like, sound like drugs. And Tolman lettering as per ISMP. ISMP is Institute for Safe Medication Practice. 11th, drug interaction. Definition, types of drug interaction, clinical significance of drug interaction, and how to minimize the drug interactions. Lecture 1, according to D.Pharm and PharmD. Clinical pharmacy, its definition, scope, development in India and other countries. Definition. Clinical pharmacy. It is the branch of pharmacy that involves supply of patient care. Patient care includes how the patient is being treated while the treatment is given to him, how the medicine are acting upon him, how the treatment is effective for him. With the utilization of medicines, outcome of the patient to promote wellness, that patient is being cured and the disease is being prevented. In short, clinical pharmacy deals with the patient care and drugs and promote health, wellness and disease prevention. Next aim of clinical pharmacy: ensure patient maximum well-being, that is safe and rational use of the drugs. Second, physician should be assisted by clinical pharmacist. CP is here, clinical pharmacist. That better prescribing should be there and monitoring of drug therapy. That the doctor should prescribe the drug accordingly to the patient disease condition state, and drug therapy should be monitored daily by the nurses at frequent intervals. Third, to maximize patient compliance, that is the better outcome and free from ADR, that the result should be the patient should be prevented from the disease and there should be no ADR. ADR is adverse drug reaction to the patient after the drug is given to him. Rational use. Rational use is that there should be no misuse of the drug. No overdosing should be given to the patient. Educate dose. That is, right dose should be given. Right drug, right dose at right time. That outcomes. Cure of the disease. That disease should be cured. Second, elimination, reduction of symptoms. Disease should be eliminated, symptoms should be reduced, and disease should be prevented. Prevention of disease and symptoms. Symptoms of the disease should be prevented. There are some qualities that a clinical pharmacist should possess. Qualities of clinical pharmacist: communication skill, clinical skill, professional skill, empathy, monitoring drug therapy. Communication skills, that clinical pharmacist should have a good communication skill, should convey with the patients with easy language that is understandable to the patient. According to the state, it can also vary. Clinical skill: a clinical pharmacist should have a thorough knowledge about the drug, its etiology of the disease, symptoms, pathology, pharmacokinetics, pharmacodynamics and laboratory test investigations should be known to him. Professional skills: it is the interprofessional skills. The link between the doctor and nurses should be well made so that it can be easily conveyed about the disease, its symptoms, its etiology, if any modification in the test or the patient disease is to be made. Accompany drug information. As clinical pharmacist is a person who is expertise in this task. So if any new drugs come, so he should make aware to the doctor about the possible side effects and ADR which can lead. Empathy. Empathy is a deep sense of responsibility towards medical care of the patient. That one should think that this disease is also its own disease and should prevent it properly. Monitoring drug therapy. It is the ongoing process or the treatment. Daily basis, it should be checked and if needed to be changed or modify the therapy. As monitoring of drug therapy is done daily basis by the nurses or the clinical pharmacist, that the drug is at given right time, right dose or not. If any modification according to the patient age or disease condition severity, it should be done. Next will be the scope of clinical pharmacy. There are 11 scope of clinical pharmacy. We will be discussing them in detail. Number 1, preparation of patient medication history. Second, bioequivalence and generic equivalence of pharmaceutical formulation. Third, patient monitoring and TDM, therapeutic drug monitoring. ADR, adverse drug reaction and drug interaction. Fifth, rational prescription. Sixth, drug diagnostic test inference. Seventh, intravenous admixture. Eighth, drug information specialist. Ninth, discharge counseling and patient compliance. 10th, medical audits. 11th, clinical research and education programs. Now we will discussing them in detail. Scope of clinical pharmacy in India. Number 1, preparation of patient medication history. By asking patient or by counseling the patient, it includes medication history, the previous history of the drugs the patient is taking, drug allergies, if any patient is allergic to any food or any drug, that should be noted. Any hypersensitivity of any drug or any other agent should be noted down. Food habits, that the patient is alcoholic or smoker, it should be written, or if he consumes spicy food, etc. Smoker or non-smoker should be mentioned. Pre-existing disease, like some disease like diabetes and hypertension, it should be mentioned in the previous history of the patient. Second, bioequivalence and generic equivalence of pharmaceutical formulation. Clinical responses may be different in according to the bioavailability. Bioavailability is the rate and extent at which a drug shows its reaction to reach the target site. Many factors influence the bioavailability of the drug, and every drug has a different bioavailability and bioequivalence. So therefore, monitoring of every drug should be done on daily basis. For selection of proper and the best drug therapy according to its bioavailability and its bioequivalence, the drug should be selected. Third, patient monitoring, therapeutic drug monitoring. Therapeutic drug monitoring is also known as TDM. It is to keep a check on a patient. पेशेंट को हम डेली बेसिस पे देखेंगे ऑन द बेसिस ऑफ साइड इफेक्ट ऑफ द ड्रग, toxicity effects and any contraindication of the drug. It is the main task of the clinical pharmacist, as this person is a best knowledgeable person who knows about the drug routes, sign and symptoms, desired side effects, possible side effects, if any ADR, pharmacotherapeutics, pharmacokinetics of the drug. So therefore the clinical pharmacist helps the physician to correct the dose therapy for the safe and effective treatment, which number 4, adverse drug reactions and drug interactions. Adverse drug reaction is ADR and drug interaction is DI. Adverse drug reactions are the unwanted reactions associated with the use of drugs, may or may not related to the drug. Therefore, the clinical pharmacist is a specialized person who detects, who sees the ADR and helps in preventing the ADR and reporting the ADR. Detection of ADR is done by seeing the patient file. Secondly, we see the patient if any area of his hand, leg is affected by the reaction, then prevent by giving him the anti-allergic drug and reporting the ADR on the ADR form and then reporting it on the government portal, that is the Wigi flow, and alternating the drug therapy, that if the drug is causing the ADR, any other alternative drug is given to the patient. Drug interactions can also be checked by anyone by Medscape. Medscape is an app in which we can put the name of all the drugs. Then we see the drug interactions of it. Number 5, rational prescription. Clinical pharmacists suggest the physician and help him in finding the right drug, right dose, right route, and right duration gap. That the drug given to the patient should be the right one, right dose, and the right route of the drug should be there, and the duration gap should be the frequent intervals should be managed in a proper way, that no overdosing and no misuse of the drug is be done. Sixth is drug diagnostic test inference. Clinical pharmacists, that is CP, point out alternated drug results due to the drug and enormous diagnostic. Like ड्रग डायग्नोस्टिक्स टेस्ट के अंदर जो क्लिनिकल फार्मासिस्ट है वो चेक करता है जो भी रिजल्ट्स ऑफ द टेस्ट आर देयर, what is the possible and the best result of the disease prevention, which treatment can be given to the patient to prevent the disease. Seventh is intravenous admixtures. That preparation of admixtures, like whatever the drug we are formulating, it should follow the aseptic conditions. That room should be no entry of the any person should be there, only gloves weared person should go. Every condition of the room temperature should be maintained. Proper calculation of the dose should be done. Rate of administration of drug, monitoring incompatibilities should also be noted down on the daily basis. Proper formulation of TPF, like TPF is the total parenteral fluids, the fluids which we are making, electrolytes, it should be daily basis monitored by the clinical pharmacist, that the level of the insulin as given to the patient is 5 units. It should be monitored that 5 units is given at a appropriate interval to the patient, that no overdosing is there, no misuse of the doses being seen. If there is any overdosing or misdose seen, it should be corrected by the clinical pharmacist. 8th, drug information specialist. Clinical pharmacist helps the physician and nurses by providing the information about any medical emergencies, what are the antidotes to be given to the patient, if any overdosing is there, how to correct it, prevention of the ADR. The ADR is being prevented by minimizing the dose, changing the alternative route of the dose, alternate drug should be used, or by giving the anti-allergic drugs to prevent the ADR. Effective utilization of the drugs, that the drug should be effectively utilized by the patient at right time, right dose, right interval. Therefore, clinical pharmacist can also help the patient by providing the information about how to take the drug, when to take the drug, what are the possible side effects of the drug, possible adverse drug reactions, possible contraindications of the drug should also be told to the patient. 9th, discharge counseling and patient compliance. By educating and counseling patient at time of discharge from hospital, that when the patient get discharged from the hospital, we should make him aware about the purpose of the medicine, what the disease patient is suffering from, what is the purpose of the medicine, proper way to take the medicine, proper scheduled time at which he should take the medicine, storage condition, like some drugs are to be refrigerated, some drugs are to be kept at room temperature, what are the possible side effects of the drug, like side effects of the drug and the food interactions, like when we consume the iron tablets, the stool color changes into the black. Common food interaction like calcium and antibiotics should not be taken together. Green vegetables and anticoagulants should not be taken together. Activities to avoid during the treatment, like if person has difficulty in bending, he should not bend, it should be avoided. If the person is not able to lift the heavy weight, he should not lift the weight. Like in pregnancy, we should not lift heavy weight, we should not work, we should not bend in excess. 10th is medical audits. Audits are the logical and necessary procedure within organization teamwork. Audits are to be done on the daily basis. Activities of the audits. First is legislation. Legislation is to make the laws. That laws have to be followed on the daily basis in the hospital. Contractual obligations. That is the duties and responsibilities to be fulfilled by the hospital faculties. Regulation and resignation of pharmacotherapy orders and administration. Daily basis we have to regulate the pharmacotherapy, that is the treatment given to the patient should be well and perfect one. Regulation of clinical experiments with drug. If there are any clinical experiments with a drug, new drug is going on, it should be noted on the daily basis that this patient is having this effect with this drug. What are the possible consequences of this drug? What are the possible side effects of this drug? Next, medical audit and community work. Daily basis audits related to the hospital, daily patients prescription audits. There should be no overdosing of the drugs. And community works. It's include the therapeutic committee should annually meet and discuss about what the changes and modifications are needed in the hospital. Retrospective study of the drugs. It examines the drug's use pattern, how the drug is being used in the hospital in the daily basis. Identifying adverse event. A is adverse event. डेली बेसिस पे एडवर्स इवेंट्स को आइडेंटिफाई करना. ड्रग एरर्स, लाइक कोई भी मेडिकेशन एरर्स हो रहे हैं, प्रिस्क्रिप्शन एरर्स हो रहे हैं, and any other errors. Daily we have to note down the errors. Like prescription error is the error which is being done by the prescriber by not writing the proper dose. In that case, overdosing can be the possible error effect. 11th, clinical research and education program. The clinical pharmacist can also work in a clinical research area and education program by making aware about the programs and investigational drugs. These drugs help in conducting of the clinical trials. Like clinical pharmacists can also participate in the clinical trials, conduction of the clinical trials, and can conduct the training for the physicians, pharmacists, paramedical staff and the nurses. These trainings will be related to the medication errors, drug interactions, ADRs, etc. or if any drug which come new into the market, and if any drugs which was not earlier causing any side effect but now it is causing the side effect, it should be made aware to every person in the hospital, including physician, pharmacist, paramedical staff and nurses. If any ADR is noted, it should be reported immediately so that prevention can be done. Next topic is development of clinical pharmacy in India. That is how clinical pharmacy developed in India. The educational qualification for the post of clinical pharmacist is PharmD, that is Doctor of Pharmacy, and M.Pharm Pharma Practice. Development of clinical pharmacy. In 1953, D.Pharm, that is Diploma in Pharmacy, was the minimum qualification for pharmacy practice, community and hospital setting. In 1980, consequences of drug misuse. In 1980, the drugs were misused in a bulk amount. Poor health outcome. The outcome of our health was very poor at that time. Economic loss of the patient. In 1990s, it was the awakening period as the improvement of medication use was seen at that time. And the awakening period program conducted on the daily basis to make the physicians, nurses and paramedical staff aware about the patient care practice, safe use of the drugs, about the drug pathology, drug pharmacology, drug pharmacokinetics and the skills to be implemented. The result, by making the every person aware, it result in expansion of pharmacy profession in India from technical industry use to the role play in healthcare system. That now after the 1990s time, the study of pharmacy profession is not only stick to the industry, now it is also to the hospital settings. Early institutions for clinical pharmacy when started. Number 1 was Delhi College of Pharmacy, Delhi University in 1892. Second is JSS College of Pharmacy, Mysore, 1996. Third is JSS College of Pharmacy in Ooty, 1997. These all started with the D.Pharm pharmacy practice. In 2015, Regulation, Role, Responsibilities, Code of Ethics, Standard, Qualification was fixed for the profession of pharmacy. Need of clinical pharmacy in India. Why we need clinical pharmacy? For the promotion of effective, safe and economical drug therapy. That drug should be safe, effective, that is the treatment should cure the disease. Economical drug therapy, it means cost effective treatment. It includes dispensing and drug distribution, that the drug should be dispensed properly and distributed accordingly. Drug information, what the patient is suffering from the disease, its treatment, its cure, if any possible side effects should be noted to the patient. Health promotion, by creating and conducting the awareness camp for the patients and the hospital staff for any new drug or any new drug treatment or therapy should be told. Patient counseling, counseling the patient about its disease, things to avoid while the treatment is going on, how to take the drug, when to take the drug, possible side effects and ADR to be told. Pharmacovigilance, it is to keep a check on a drug. It includes assessment, detection, management and prevention of ADRs. Medication review, review of the medications given to the patient when he is in the hospital, that it is given on right time, right dose, right duration or not. Sterile and non-sterile manufacturing. In India, we have five main. In India, we have 5 main persons behind the clinical pharmacy profession. Number 1 is the pharmaceutical industries. There are 60,000 formulations available in the market. But we are lacking behind as medical information department is not there. Consumer product information, that is the information about how to take the drug, is also not told. leaflets are missing. Therefore, clinical pharmacist is the person who provides unbiased, independent drug information. That clinical pharmacist is a person who provides the drug information about the new drug to the doctors and the patients. Second is prescribers. As the patient load to the physician is increasing day by day, the physician is very busy and physician gives a pill for every ill, but this is a very wrong practice. The physician or the doctor should prescribe the drug by the brand name. That avoids the risk of duplication of therapeutic equivalents. Therefore, clinical pharmacist is a person provides doctors the advice and information to deliver safe and more effective drug therapy. That the patient should be given the safe treatment, effective treatment, that the cure should be at the high rate, that there should be no pill for every ill. Firstly, the patient history should be known, then after the drug is to be given to avoid the risk of the duplication. Next is the third, pharmacist. Mostly pharmacists do not give the patient counseling, as many pharmacists are not aware about the uses of the drug, how to take the drug, when to take the drug, so they do not make patient aware. Number 4 is government. Clinical pharmacist reports ADR on the government side, that is Wigiflow. It is the portal where we report the ADR of the drugs which are causing the ADRs in excess. Every company, hospital reports the ADR here. After reporting, when the drug is seen that it is causing the ADR is life threatening or the death, then that drug is banned. Number 5 is patient. Patient counseling should be done about the drug in detail. How to take the drug, when to take the drug, duration, interval, possible side effects, ADR, food interaction should be told to the patient, and the treatment should be cost effective treatment. Last topic of this module is development of clinical pharmacy in other countries or the Western countries. In 1928, pharmacist participation in ward round was seen in the University of Iowa Hospital. In 1945, training in clinical pharmacy was started in University of Washington College of Pharmacy by L. Waite. In 1950, PharmD was launched in University Southern California and other universities. In 1960, first office-based pharmacy practice and use of patient medicines by Dr. Eugene White in Berryville, United States. In 1962, first DIC, that is Drug Information Center, was made, which gives information about the drugs, how to take, when to take. By University of Kentucky Medical Center. 1969, there was revision of American Pharmaceutical Association, that is APHA. Revision was of Code of Ethics was forbidding pharmacists to prescribe and discuss therapeutic effects of the drug, how to prescribe the drugs and the therapeutic effect of the drugs were discussed in it. 1972, prescriptive authority to the pharmacist in USA. In 1972, pharmacists were given the prescription authority. In US, pharmacy practitioner training program helped the pharmacist to prescribe the drugs. In 1976, formation of Board of Pharmacy, that is BPS, by American Pharmaceutical Association, which helped in developing skills of clinical pharmacists in certain specialty. This was all about the clinical pharmacy, its scope, its development in India and Western countries.